Assalamu alaikum, everybody. My name is Eman Chaudhri, as some of you may know. And today I'm going to be giving you guys the Neurology OSPE crash course, or like a quick review for the OSPE that you guys have tomorrow with your neuro exam. And this is going to be going over the more important topics of the OSPE that are recurring throughout your past OSPEs, and recurring topics that generally come in your exam a lot. But of course, this is more catered towards the OSPE, okay? So I understand that this is, of course, a recorded session. So if you guys have any questions at all, please feel free to reach out whenever you need to after this, in whichever way you feel comfortable. Texting if you need to DM me, or if you want to send an email. All right, all my information at the end. So we're just going to jump straight into questions. We're going to go into ones that have come before, things that maybe you need to like review last minute or something, and it's okay. Whatever you do last minute will help you. And yeah, all right. So without further ado, let's just start. Okay. So the first question over here is a physiology question. And while a lot of people forget that physiology is actually an important aspect of the exam, it's not as many questions, but it will come up. So over here we have a diagram, and we can see two things on the arm. Okay. So we'll say that this is about nerve stimulation. So the nerve is stimulated at point S over here, and the response is recorded at R, around 28 centimeters away. So if the latency is 4 milliseconds, calculate the conduction velocity of the nerve in meters per second. So it's really important to understand how to calculate conduction velocity, and it's also very simple. So when we're looking for conduction velocity, it is basically the distance over the time. So over here, the conduction velocity would be the distance over the time, or the latency, sorry. And because we want it in meters per second, and currently the units that we're given are centimeters and milliseconds, we're basically going to be dividing it by the respective numbers to get to the correct unit. So for meters, to get from centimeters to meters, we're going to divide it by 100. And to get from milliseconds to seconds, we're going to divide it by 1,000. So the conduction velocity over here would be the distance over 100 over the latency over 1,000. So that would be 28 centimeters over 100 and 4 milliseconds over 1,000, which gives you 0.28 over 0.004, which will give you 70 meters per second. And this is your conduction velocity. And that is as simple as that. So it's just basically a very quick, simple equation, and you just put in your values. Just remember to take care of the units whenever you need to, such as in this case, and you have your answer. All right. And for physiology, this is typically what you will get. It's usually no more than this. You might just ask for your understanding of a specific concept, but that's the maximum from what I have seen, what I have experienced, and what I was looking at when I was preparing for the session. All right. So the next now is going to be the histology stuff and some embryology stuff as well. So besides just questions, I'm also going to be showing you a few slides of just review. And these are things that you need to remember when you're going to be doing your exam, or when you're going to be doing your OSPE, okay? Things that kind of reoccur. So over here, we have a histologic image here on the right. And so what we have to answer the two following questions. So in your OSPE, it might come up like this, like, okay, answer the two following questions based off of this one diagram or this one image, etc., or this slide, basically, this histology slide. So over here, we can see that, yes, it's neuro, so we know that these are nerves. And this is, I forgot the name of the cut. It's okay, it's not transverse, but basically we're looking at them longitudinally. So over here, what we can see is we're not looking in the nerve like a tube, but we're looking at it like from the outside longitudinally. So what is a structure? These are nerves, but what is the specific structure that is circled over here? So we remember that nerves are myelinated, and when they're myelinated, there's like a little break in between. And over here, we can see that break over here because it's not continuous, for example, like it is under here, until it also stops over there and it continues on. Over here, we see the break. So that break is known as a node of Ranvier, or like multiple nodes of Ranvier, okay? And what's really important when we're doing histology, and this is a reminder I always give students, is when you're looking at a structure, always relate the structure to the function, because that's why we have to know the structure in the first place. So the nodes of Ranvier, or the breaks in myelin, are there because it is for saltatory conduction. Basically, we want the current to be going for the exchange to be occurring and then to continue on, because these are going down very long nerve fibers. And this way we can have faster impulses. So this is known as saltatory conduction. So the nodes of Ranvier are very important for that. And that is why, and this is actually an important concept also because when you guys get other questions, for example, about Guillain-Barré syndrome or other demyelinating diseases such as multiple sclerosis, this is a very important concept because you kind of lose the nodes of Ranvier, so you don't have saltatory conduction in the same way because you have a lack of myelin, so the breaks are bigger, so it's not necessarily like a traditional node of Ranvier or like nodes of Ranvier. You're going to have more space and therefore there's going to be more exchange, and then the current dies out over time, and therefore there's weakness, there can be spastic paralysis, etc., depending on what type of disease that you have and which nerves are primarily affected, right? So that was just like a little pearl, I guess, for you guys, but this is an important concept to understand, okay? So, nodes of Ranvier, saltatory conduction. This has come up since first year in terms of histology, and it's very, very important, and it might come for you guys, so just remember this, okay? Now we're going to go into the embryologic origins. Just give me 1 second. All right, okay. Oops, sorry. How do I go back? Okay. So in the embryologic origins, now we're going to be looking at this because some of your questions in your OSPE are going to be like, hey, this is a problem in a specific type of structure, but which structure, number one, do you think it is? And which embryologic origin is it, basically? So I forgot exactly what it's called, but kind of like second degree reasoning, where it's not just asking like, oh, this is the problem, what is the structure affected? It's going to be like, this is the problem, the patient, what is the embryologic origin of the structure affected? So it's basically like you have to answer two questions. You first have to understand which structure is affected. And once you know which structure is affected, you have to know what the embryologic origin is. And you guys already know how to do this from studying for your midterm and from looking at it up until now. But basically, we just need to remember specific embryologic origins so that we can remember how to answer those questions. So in our neural development, there's a neural plate, the notochord, and then there's folding that occurs, and then we have the neural tube, and we have our neural crest cells. These all give rise to different structures in our nervous system, in the central and peripheral nervous system. So for example, the neural tube and all this will become, sorry. This all will become part of the central nervous system. The neural crest cells then become, for example, myelin. They will give rise to peripheral nervous system neurons, the dorsal root ganglia, glial cells such as Schwann cells, which make myelin, satellite cells, and then they'll also give rise to adrenal medulla, which are the nervous part of the actual adrenal gland itself. And then, for example, in the neuroepithelia in the neural tube, is going to give rise, like I said, to the central nervous system, so the CNS neurons, the CNS glial cells, okay? So the astrocytes, oligodendrocytes, and ependymal cells within the neural tube. So for example, if you have a question about, for example, an astrocytoma or an ependymoma, then you know, for example, they could ask, for example, what is the origin of the type of cell that is giving rise to this tumor? And you can say neural tube, so neuroepithelia and the neural tube. For example, if it's a schwannoma, then you know that the origin is neural crest cells. If the problem is multiple sclerosis or GBS, Guillain-Barré syndrome, you know that it's demyelinating and the problem is in the myelin, and that the origin of myelin from Schwann cells is the neural crest cells, because Schwann cells arise from neural crest cells and Schwann cells make the myelin. Okay, so just think of it that way. So just remember to relate origin to type of cell and what those cells' functions are, okay, and where they can be found. And then we have the brainstem and the cortex. So we have the telencephalon is the first part, then the diencephalon is the second part. So di-2. And then the rest is arranged alphabetically. So mesencephalon, metacephalon, myelencephalon. So over here we have the telencephalon. Over here we have the forebrain, midbrain, and the hindbrain, right? So the forebrain or the prosencephalon will give rise to both the telencephalon and the diencephalon. And the telencephalon will give you the cerebral hemispheres or the cortices, as well as your lateral ventricles. And then again, the forebrain will give the diencephalon. Diencephalon gives you your thalamus, hypothalamus, retina, and the third ventricle. So again, think about when you see these things, how the questions can arise from these. For example, if a person has a blockage in their foramen of Monro, and we know that the foramen of Monro connects the lateral ventricles to the third ventricle. We know that there's going to be enlargement of the lateral ventricle. So enlargement of a structure arises from which of the following embryologic structures? You know that the lateral ventricles then arise from the telencephalon, so that would be your answer. For example, if a person had a thalamic stroke and they're like, okay, this is a stroke, these are the symptoms, what is the embryologic origin of the cells affected, or of the part of the brain that is affected? Then you can think, okay, thalamus, that comes from the diencephalon or the forebrain, right? So just think of it that way. So after the forebrain, we have the midbrain, which gives us the mesencephalon, which gives us the literal midbrain, and the cerebral aqueduct. Okay, so each gives us a wall and cavity. So the walls are like the actual structures, and the cavities are giving the ventricles and the other ducts. Okay, the hindbrain will give us the mesencephalon and the myelencephalon, and the mesencephalon will give you the pons and the cerebellum, and the myelencephalon will give you the medulla, which is the lowest part. Okay, and then when you know this, then you can answer the questions about embryologic origin. So for example, what is the embryologic origin of myelin? So you might get this, or you might get a case, for example, a really long vignette about a 22-year-old woman came complaining of vision loss from time to time, as well as weakness in her leg that has been occurring on and off for the past 2 years. Structure of which of the following embryologic origins is affected in this patient? So you might know, okay, this is giving a picture of multiple sclerosis, which affects myelination, and therefore myelin, which comes from Schwann cells, arise from neural crest cells. So what is the embryologic origin of myelin? Neural crest cells, and that would be your answer. Okay. So now we're going to jump into the anatomy. And the anatomy over here, we're going to start with something that I feel people will often forget, especially when they finish neuro, because it's not as discussed, I guess, as the other vasculature of the brain, for example, the arteries, but it is the drainage, or the venous drainage of the brain. So we know the vasculature, and I'm going to go into that in a minute, but let's go over the venous drainage of the brain first. Over here, we can see the lateral view, or a sagittal cut, basically, of the brain. We can see the corpus callosum, the lateral ventricle, etc. We can see the superior sagittal sinus, the straight sinus, and everything. And we can even see the cortex as well, the cerebellum and the brainstem and everything. Now, one important thing in the OSPE anatomy that they really like to ask you about is, of course, your cavities. So your ventricles, your ducts, etc. So we have to remember the order of everything from lateral ventricles down to the fourth ventricle, and how they're all connected, etc. Right? And where the CSF is basically going through and how it's being drained. So we can see over here. Okay, just wanted to label this a straight sinus because it wasn't already labeled. But we know, okay, these are the lateral ventricles, and we have the foramen of Monro that leads you into the third ventricle. Then we have basically the cerebral aqueduct of Sylvius. Then we have the foramen of Luschka, foramen of Magendie. Okay, so the lateral ventricles, then the foramen of Monro, or the interventricular foramen, more commonly referred to as the foramen of Monro. Then we go into the third ventricle. Then we go into the aqueduct of Sylvius, which takes us to the fourth ventricle. And the fourth ventricle will basically release the CSF via laterally, LL, lateral Luschka, laterally through the foramen of Luschka, and medially through the foramen of Magendie. So medial Magendie, lateral Luschka. Okay, and we can see the M. So we can remember this by the what do you call it? Mnemonic, the mnemonic Muslim, basically. So MSLM. Okay, so M Monro, S Sylvius over here, L Luschka, M Magendie, and that's it for you guys. So Monro, so lateral, Monro, third, Sylvius, fourth, Lushka, Magendi. LL, Lushka lateral, medial Magendi. Okay. Now over here, it's important. This I put over here for the sake of looking at the venous drainage and where everything flows, etc. We have the cavernous sinus, which is at the basically at the skull base. You have your sinuses that basically your venous sinuses that flow over here. So we have the straight sinus like we saw over here. It's the same thing over here. We have our transverse sinuses over here. And we can see this as well. This is the superior sagittal sinus, the inferior sagittal sinus, straight sinus, and then the great cerebral vein of Galen. Okay, then we can see the transverse sinus over here. We can see the confluence of sinuses, basically where they all converge and meet. And one thing that I forgot to actually touch on is over here. Sorry. We have our arachnoid granulations, which is basically where the CSF flows and drains into the venous sinuses as well. All right. So when you see this, and when you understand this, then you're going to sometimes get a radiologic image such as this. And you're going to be asked to label the following structures. So label each of the following structures. So we know from what we just saw, and I know they're kind of labeled over here, but pretend you can't see over here. A over here, this would be the superior sagittal sinus. Then we come down, and then D would be the straight sinus. B would be the inferior sagittal sinus, and C would be the great cerebral vein of Galen. Okay, so A, superior sagittal sinus, B, inferior sagittal sinus, C, great cerebral vein of Galen, and D is the straight sinus. Okay, and it's just as simple as that. And this is another way to look at, this is from first aid. This is a lot more like the image I just showed you guys, radiologic image, where you can see this superior sagittal sinus, inferior sagittal sinus, straight sinus, and then the great cerebral vein of Galen, such as that you can see over here. It's the same exact angle, but just the other side. All right. These will all eventually converge and meet in the confluence of sinuses, and they will go and they will drain into the jugular veins eventually. Then now we look at the cortices or the cortex of the brain to see the separate parts. And understanding this will help us understand, for example, specific cortical deficits in patients with strokes and patients who hit their head, who have transient ischemic attacks, etc. So we have the frontal lobe, the parietal lobe, occipital lobe, and then the temporal lobe, which is not pictured here, but that also contains part of the limbic system, especially the inferior part. Okay. Now we also, in the center, we have the thalamus. At the base, we have the pituitary gland, and then we have the brainstem as well, and then the cerebellum. Okay. Now it's important to remember which parts are where. So, for example, the primary motor cortex is actually in the frontal lobe. Somatosensory is in the parietal lobe, etc. And then when you have aphasia, you have to remember which parts are affected. So, Broca's, it's going to be frontotemporal, and then Wernicke's, it's going to be more parietal temporal or temporal. Okay. So over here, this is in a CT scan, or sorry, MRI. Over here, we can see the different parts of the brain, which we just saw over here. But this is obviously without the highlighting and labeling in the same way. See the corpus callosum. This is the frontal lobe, parietal lobe, occipital lobe. Here, not pictured, but we would have the temporal lobe, then we have the limbic system, etc. And you can even see, for example, the cerebellum, lateral ventricle. We can see the fourth ventricle over here, the third ventricle up there, etc. All right. Now to review the vasculature of the brain, and the reason that I'm touching upon this, and you guys maybe already know it very well, is because a lot of your anatomy questions in your OSPE and outside of your OSPE will arise basically from the circle of Willis and the general vasculature of your central nervous system, to see your understanding or assess your understanding, not just of the vasculature of where things are flowing, but of what happens basically if a specific part of the brain's blood supply is cut off. And they want to assess your understanding to see if you understand what that part of the brain is responsible for via asking about the vasculature. Okay. So we have our basilar artery. We've got our internal carotids, etc. Just give me 1 second. I don't know what's up with my eye. Okay. Our internal carotids that give rise to the middle cerebral arteries that go laterally. We have our anterior cerebral arteries and an anterior communicating artery, which is where berry aneurysms most likely arise or most commonly arise. And then those are heavily implicated in subarachnoid hemorrhages or hematomas, etc. We've got our posterior cerebral arteries that flow to the back, which are not properly pictured here, I think. Never mind, they're right here. They go around the brainstem and then down to the back. And over here, we can even see, as we go down, our vertebral arteries, they give rise to our picas, which are most commonly affected in stroke. So for example, lateral medullary syndrome or lateral medulla syndrome, the pica is implicated over there. And you're going to have specific deficits that show at that time. So for example, contralateral hemiparesis, ipsilateral hemiparesis, contralateral sensory loss. You're going to have slurring of speech because of motor deficits of the tongue. You're going to have drooping of the face, uvular deviation, etc. Okay. So over here, when we understand the vasculature of the brain in this way, then we can understand it in the actual radiologic image. So occlusion of which of the following label structures will result, for example, in aphasia. So we know that aphasia occurs either Broca's or Wernicke's aphasia, whatever it is. Those are implicated in when a specific part of the hemisphere is affected. And those are most likely due to middle cerebral artery damage. Now, when we understand that, then we can see, okay, which of these is a middle cerebral artery? And the answer would be B. So aphasia can happen, Broca's, for example, frontotemporal or frontal lobe, and Wernicke's if it's parietotemporal or the temporal lobe. But most of the time, both are implicated in middle meningeal artery. Middle cerebral artery occlusions or problems, okay? Now we could rephrase this question with the same image and say, occlusion of which of the following label structures will result in lower limb weakness or loss of sensation? So if we understand the homunculus of the brain, remember that most medially, we have our lower limb, genitalia, and as we move outwards, we have more of our face, our upper limbs, and then most laterally, we have our mouth, tongue, gums, teeth, etc. Okay? So occlusion of which of the following label structures will result in lower limb weakness or loss of sensation? So if we review the vasculature over here, we remember that middle cerebral arteries are going laterally, posterior cerebral are going posteriorly, and the anterior cerebral arteries are going anteriorly, and also they stay medially. So we know that, for example, if because of the homunculus, lower limb and genitalia are medial, and we know that the anterior cerebral artery runs medially, the answer over here would be C, okay? Now, occlusion of which of the following label structures will result in vision loss with macular sparing? Now, we understand that the posterior cerebral artery is going posteriorly to the occipital lobe, which is responsible for our vision and our sight and understanding of sight and what we see day to day. So our posterior cerebral artery will be going to the back, and we know that this is basically the one that goes around the brainstem posteriorly to the occipital lobe. So, our answer would then be E. All right. Not supposed to see the answer there. But for example, another way that they can ask you a question about your, for example, cortical deficits, etc., is a 9-year-old girl falls down and hits her head, and she is now showing signs of docility. Which highlighted area is affected? So we know that docility, and some behavior, etc., is affected when the limbic system is affected or if the frontal lobe is affected. But over here in this case, it is a temporal lobe. It's basically like behavior, and the temporal lobe is affected. So green. Now, a 9-year-old girl falls down and hits her head, and motor function is affected. Which of the highlighted areas is affected? So we know that the primary motor cortex is in the frontal lobe, so hence our answer is going to be blue. Now, if the question was asking more about sensation, then we can go ahead and safely say yellow. Or if it's eyesight with macular sparing, for example, then we can go ahead and say red. The macular sparing is a very good hint as to what is affected, and it's typically the occipital lobe. Now, this is another interesting question, and this is a little bit more challenging, but this is something that has come in OSPE before. So a 55-year-old hypertensive woman presents with sudden freezing, painful sensations in her left arm. And she has left-sided weakness. And when examined locally, she was weak and numb on the left side with chorea of the left arm. So which structure is most likely affected in this patient? So over here, we have a few clues in our question. So she's 55, sure, but she's hypertensive. She has a sudden freezing, painful sensation in her left arm. That's focal. It's not like she has it on the whole left side of her body, but she does have left-sided weakness. And when examined locally, she's weak and numb in the left side with chorea of the left arm. So because there is like a focal deficit, and it does start with, it's mainly sensory, we can safely say, and also because of the history of hypertension and the type of strokes that hypertension can predispose you to, we can tell that this is more inside the brain. This could be like a lacunar infarct, for example, or a burst vessel. And a lot of the lenticular striate vessels can also give rise to vasculature of the thalamus. So we know that this possibly can be a thalamic stroke, and therefore the answer is D, thalamus. And we know this because, for example, people might say, oh, but she has left-sided weakness. How do we know it's a thalamus? There's also a very obvious focal sensory loss or focal sensory deficit or problem. So for example, the sudden freezing, painful sensation in her arm, and with the history of hypertension, we can safely say, for example, the types of vessels that are affected here are the smaller vessels, such as the lenticular striate muscles, which give rise to also the internal capsule. And as you can see, the internal capsule over here is actually not highlighted. Otherwise, that could also be correct in this case. Okay. Over here, we only have parts of the nuclei that are highlighted or labeled, I mean. But over here, so it's a thalamus specifically that is affected and we know that because of the focal sensory problem, and therefore the answer is D. Okay. If they also labeled the internal capsule, technically that could be correct and you could appeal it. Now we move on to herniation syndromes. This is another thing that your OSPE will touch upon a lot. And it's very simple and straightforward to the point. We just need to understand that if a brain moves a certain way, we need to remember again, what is that part of the brain responsible for? How can it be affected if it is compressed, if it is stopped from doing its function, right? So 1, 2, 3, 4. Let's see each of these, basically what happens when there's 4 types of herniation that are talked about over here. So number 1 is subfalcine. So we know this is the falx cerebri, so subfalcine, under the falx, under falcine, subfalcine herniation. This is when we have the herniation under the falx cerebri and it can move to one side and it's compression basically medially. And therefore, this can compress what runs medially, which is the anterior cerebral artery. So we know that if the anterior cerebral artery is affected and if the nerves that are more responsible, when we remember the homunculus of the lower limbs and the genitalia, we can say or go ahead and say that there can be lower limb problems or weakness, okay? Number 2 is central or downward transtentorial herniation. This can cause displacement of the brainstem eventually, and therefore it can be fatal. It can cause hemorrhages as well, etc., because of rupture of the paramedian basilar artery branches, okay? But this is, at least in my experience and from what I have seen in your guys' exams, this is the least spoken about, but it is obviously important to know because it is there, right? But this is the least spoken about type of herniation. 1, 3, and 4 are a little bit more commonly tested. So number 1, we know is subfalcine. Number 2, we just said is central downward transtentorial herniation. And number 3 is uncal transtentorial herniation. So the uncus is the medial temporal lobe, and the medial temporal lobe will basically move and it will herniate. And what can happen over here is because it is herniating in a way where it is compressing the upper part of the brainstem, which we know gives rise to cranial nerves 3, 4, for example, especially cranial nerve 3. We know that when there's herniation, because it's happening on one side, we can actually have an ipsilateral oculomotor or cranial nerve 3 palsy or problem or compression. So we know that cranial nerve 3 compression can lead to a blown pupil, and it can lead to problems in eye movement as well, except abduction and whatever the trochlear nerve does, unless the trochlear nerve is also affected, but typically that's not always the case, okay? And it can lead to something called Kernahan phenomenon, which is basically contralateral blown pupil because of the pushing of the brainstem. So instead of just the ipsilateral, it's going to compress the other oculomotor nerve. And ipsilateral hemiparesis due to contralateral compression against the Carnahan notch. Okay. Number 4 is cerebellar tonsillar herniation. And this is the most fatal in terms of it can most quickly lead to death or coma or death. And it's because of the herniation compression of the brainstem, which is the most immediate. And the rest, you can also get compression of the brainstem immediately. They present a little bit later. But over here, it's most commonly earlier in its presentation. Okay. So when we know the types of herniation, then we're going to get this question. This is straight from an OSPE before. What types of herniation are the following? So we know that, okay, falx cerebri, A is subfalcine, B is uncal herniation, and C is cerebellar tonsillar herniation. Okay, so subfalcine, uncal, and tonsillar herniation. Now we can go as far to say is, for example, name a feature of each type of herniation labeled in this image. So what can we possibly see? So let's name one thing for each. So remember that when we talked about subfalcine herniation, it's medial and it can compress the anterior cerebral artery and therefore can give rise to lower limb deficits. So A, lower limb symptoms, urinary incontinence because of the anterior cerebral artery. Now B is uncal herniation, and we talked about cranial nerve 3 compression and therefore possible palsy. So therefore we can get an ipsilateral blown pupil or Carnahan phenomenon where you can get a contralateral blown pupil and ipsilateral hemiparesis. The hemiparesis and the blown pupil are usually always on the opposite sides. And late in it, we can get a coma. And in C, coma death. Again, it's the most quick in terms of causing coma and death because of the immediate brainstem compression that occurs. Okay? Now we move on to the CSF. So the CSF range values are over here. It's very important to understand how to differentiate between normal bacterial, viral, and fungal meningitis, mainly in between bacterial and viral, because these are more common, not especially bacterial meningitis. So we know that bacteria, they like to do a bunch of stuff. They like to take sugar as well. They like to grow. They like to make their own stuff in their own environment. So therefore, we know that there's going to be a turbid appearance. This is also due to the presence of white blood cells and pus formation, etc. The opening pressure is going to be elevated. There's going to be a very high number of white blood cells in comparison to the other ranges of the different types of other problems that can occur. So viral meningitis, fungal meningitis. We know the white blood cells, especially high in neutrophils, is more prominent in bacterial meningitis. The protein is high because of the production by the bacteria, and the glucose is going to be low because the bacteria are eating the sugar to do their job, basically. Whereas in viral meningitis, we're going to have clear CSF. The opening pressure may be normal. Now there's going to be fewer white blood cells, but instead of a neutrophilic predominance this time, for example, there's going to be a lymphocytic predominance. There's not as much protein production, and the glucose is going to be normal because the viruses are not consuming glucose in order to do their job the way bacteria are. And in fungal meningitis, you're going to mostly have a clear appearance. Opening pressure is going to be normal or elevated. The white blood cells are going to be a little lower, below 500. And you're going to have higher protein because fungi, like bacteria, like to make their own protein. And over here, the glucose is going to be normal to low because while they do maybe consume it to do their job, they don't do it as much as the bacteria do. And you can see these in comparison to the normal values up here. So this is going to come up, for example, people might ask you in the exam, in your OSPE, patient presented with photophobia and neck stiffness, etc. Lumbar puncture was done, and the CSF appearance was turbid. And upon further testing, the white blood cell count, for example, was 2,500, and it was neutrophilic predominance, etc. What is the most likely cause of this patient's findings? And you can say bacterial meningitis. Now, which of these are gram-negative diplococci? So we know that gram-negative diplococci are Neisseria meningitidis, which over here is number 3. It is one of the most commonly implicated organisms in meningitis, along with Haemophilus influenza and strep pneumonia. Okay. Over here we can see Cryptococcus, and in all honesty, I am forgetting these ones. All right, now we move on to the spinal cord. It's a very big part, obviously, of the central nervous system, and you will be tested in terms of, again, of deficits, okay? So When we're looking at the spinal cord, we want to know what is running where. So we have our ascending and descending tract. So ascending, basically picking up information, stimulus from your environment and sending it up to the brain. And then descending is the brain telling your body how to react, what to do, what to move, etc. So in our ascending tracts, we have the dorsal columns, which are responsible for proprioception, for vibration sense, etc. We've got our spinothalamic tracts, spinocerebellar. These are for the sake of, for example, spinocerebellar is more for the sake of proprioception, balance, etc. Spinothalamic is for the sake of sensation. And in our descending tracts, we have our motor tract, so the corticospinal tract, for example, over here as well, the corticospinal tract, etc. Okay. So when we have different parts of the spinal cord responsible for different things, and we can understand what the presentation might be in different problems involving the spinal cord. So over here, we have spinal cord problems or diseases. And if we look at them, we can see which parts are affected and what that means. So spinal muscular atrophy is, we have the gray matter and then the white matter. So in the gray matter, the anterior horn cells are affected. And over here in ALS, amyotrophic lateral sclerosis, this is a mixed upper and lower motor neuron disease. And therefore anterior horns are affected as well as the corticospinal tracts over here. And we know that because, for example, the lateral corticospinal tracts, which are the bigger corticospinal tracts, are running over here, laterally, over here, okay? Then we have complete occlusion of the anterior spinal artery. This can happen due to multiple reasons: occlusion, stroke, and hypercoagulable states, compression due to a tumor, etc. Okay, and when we have this, we know, for example, okay, the anterior horns are affected, as well as the corticospinal tract, as well as the spinothalamic tracts. So therefore, sensation, motor function, all of these are going to be affected. And if it's affected bilaterally, then this is what we can think about. And then if we know that the posterior column things are fine, so for example, vibration sense and proprioception, then that's another time that we can also think about this. Now, in the opposite way, tabes dorsalis, for example, which is something that can happen in tertiary syphilis, or for example, people can have their dorsal column affected in severe B12, vitamin B12 deficiency. We know that the dorsal columns are affected, and this is basically where the patient has a decreased sense of vibration and proprioception. Then we have syringomyelia, which is central cord is affected, and it can be in a cape-like distribution. So your hands, your arms, you're going to have weakness, loss of sensation, etc. And the reason for this is because when you have widening of your central cord, you're actually affecting the anterior white commissure over here, which is where the spinothalamic tracts are going to decussate and give off their branches as they decussate to the bilateral parts of your body, okay? So when you have compression of that, or basically stretching of the central cord into that space, then you're going to be damaging those nerves or those fibers, and therefore you're going to have a lack of sensation, and you're going to have weakness possibly. Now, vitamin B12 deficiency, like we showed, is affecting mainly the posterior column, as well as part of the lateral white matter. And in the cauda equina syndrome, cauda equina is when basically the end fibers of the spinal cord are affected, and this can lead to urinary incontinence, weakness in the legs, etc. It's typically an emergency, which you guys are going to learn about later in your medical school career, but yeah, it's important to know. Okay, so your questions might come like this. You're going to get a cross-section of your brainstem, what am I saying, of your spinal cord, and now they're going to say, okay, this is the disease, so which part of your spinal cord is going to be affected? So poliomyelitis, what is affected basically? And in polio, we know that the anterior horn cells are affected, so A, anterior horn cells. Spinal muscular atrophy, what is affected? And like I showed you guys, it was actually also the anterior horn cells, okay? And now this can be another way that you get an image. So this is also a, basically, if you just turn this 180, so this is anterior horn cells, they're now down here. And this is the lateral where the corticospinal tracts would run. This is your posterior column, your anterior horn cells. So loss of vibration sense and proprioception, for example, Romberg test is positive, point to the affected part of the spinal cord. So some of your OSPE questions might be, and you probably have already gotten this before, where it's like you click on the image in a specific part to point where the problem is. So over here, we know that this is the posterior column. So therefore, here, here, both are correct, okay? Here or here, just put it over here. Loss of motor function, we know that the corticospinal tracts are affected. So mainly, those are laterally over here. Sensory loss and paresthesia bilateral due to compression, for example, by meningioma. This could be a case that you get in your OSPE, and we know that that can be over here in the anterior white commissure, okay? Over here, because again, spinothalamic fibers are going to decussate and go their separate ways, and they pass via the anterior white commissure. Now you're going to get radiologic images as well in your OSPE, and it's important to understand how to answer the questions when you look at them and how to read it, okay? But typically, for you guys at your level, it's going to be hopefully a lot more simple and to the point, like I'm going to show you in the next 3 slides, okay? So you're going to get an image like this. What is the following image showing? And they're going to maybe ask a follow-up of which vessel is affected. So over here, we can see that it is basically going into the brain like that, and that is very typical of an epidural hematoma. When we think about epidural hematoma, then we know that the vessel that is usually affected is the middle meningeal artery, okay? Now the opposite thing here, you can see crescent formation and fluid collection in a crescent shape. So which of the following, what is the following image showing? A subdural hematoma. And which vessel is affected? Typically, the bridging veins. So you're going to have to remember to answer it like this. So just remember what you're looking at and what is affected. Now over here with contrast, for example, CT with contrast, what is the following image showing? We can say that this is a SAR sign, subarachnoid hemorrhage. Which vessel is typically affected? It's usually the anterior communicating artery due to berry aneurysm rupture. Okay. Now what if you may get a question like this? Which of the following, what is the following image showing? We can see the enhancement around and this attenuation, and we know, for example, that because it is crossing the midline and this looks generally aggressive, this is a glioblastoma multiforme. It's a type of brain tumor that's very, very serious and very deadly. And how may it present? Now, sometimes they may ask you in an OSPE to give 2 to 3 characteristics or symptoms that this might present with. So for example, if you know it's a space-occupying lesion, there might be nausea in the morning, headaches, there can be behavioral changes, seizures. So these are all correct. There can be focal deficits as well, depending on where the tumor is growing and located. But these are, for example, example answers. Okay. Now, the other thing that we're going to need to know is, for example, when it comes to the brainstem and the cranial nerves, what happens when specific cranial nerves are damaged. So I'm going to show you guys maybe one or 2 questions, but then the rest I'm going to talk about in basically to you guys. So oculomotor nerve damage, which of the following? So we know, for example, that the eye movement is not only taken care of by the oculomotor, there's also the trochlear nerve and the abducens nerve. So basically nerves number 4 and number 6, okay? Oculomotor is number 3. So we know the oculomotor is responsible for everything except abduction and basically intorsion extorsion of the eyeball, of the orbit, okay? So oculomotor nerve damage. When you have oculomotor nerve damage, you're able to look laterally or you're able to abduct. You're not necessarily able to move your eyes inwards. So for example, over here, we can see that when the patient is looking that way, they're unable to abduct. So this is an abducens nerve injury, not an oculomotor nerve injury or damage. Over here, they're able to look up and out. So this is not superior, inferior, oblique damage. Therefore, it is not the trochlear nerve problem, especially. Therefore, A is the answer. Because oculomotor nerve damage, when the patient is looking to the side, their other eye cannot follow and move immediately. Now you're going to be probably asked, for example, about a specific type of stroke syndrome, typically a pica stroke, etc. What is going to basically happen because of that. And what we need to understand is in the lateral medulla, which structures are there and what is their job, basically. And that's how you know what deficits are going to be there. So for example, glossopharyngeal, vagus, there's part of the hypoglossal nerve as well in the medulla. Hypoglossal is tongue movement. So you're going to have slurred speech. You're going to have a facial droop. You're going to have a contralateral hemiparesis. Sorry, ipsilateral hemiparesis, contralateral sensory loss because of the way the fibers run in the medulla. So that is something important for you guys to know. And this is just to review the facial nerves and their functions. And remember this for your exam. It's very, very important. But if you don't remember everything, it's perfectly fine, because when you guys do your head and neck block next, you're going to go into detail about these things, especially where they go. Another question that they can ask you, for example, about the facial nerve is, you know that the facial nerve goes to the internal acoustic meatus in the base of your skull. So if you know that, then you know, for example, that if you have a vestibular schwannoma, for example, in neurofibromatosis type 2, then we know that the facial nerve can possibly be affected besides just the vestibular cochlear nerve. And therefore we can say then facial movement is going to be affected, closing of eyes. So for example, you close your eyes, purse your lips, smile, blow like a fish. These are all taken care of by the facial nerve, okay? And yeah, but remembering this is quite important. And that is pretty much all I have for you guys for today for the OSPE review. It's very straightforward to the point, and don't overthink your answers. They're not trying to trick you, especially in an OSPE. Just remember a few details, and there's certain things you just have to remember like that. So when you do a lumbar puncture, L4, L5, you want to go into the subarachnoid space. The dura is giving the most resistance. You want to remember which part of your brain is responsible for what, where they're receiving their blood supply from, and what else? Spinal cord, like I showed you guys, and then understanding radiologic images in terms of what you've learned is going to help you a lot. So if you guys have any questions whatsoever, please do let me know. Of course, contact me anytime tomorrow before your exam. Inshallah, I will get back to you as soon as possible. And Allah yuwaffiqkum, you guys are going to do amazing. And best of luck. And Ramadan Kareem. Thank you guys so much. Okay. So